This is our annual Carol D'Onofrio Lecture in Public Health. This series honors a generous bequest of the late Carol D'Onofrio to the UCB Retirement Center. Professor Emerita of Public Health, Carol died in April 2020 after a distinguished career in the School of Public Health, the school from which she received her master's degree in 1960 and a doctorate in 1973. She served on the Berkeley faculty for more than 40 years. She was honored as the school's Alumna of the Year in 2009, and she was named one of its most influential alumni in 2018. I came to know Carol when, after retirement, I agreed to serve on two committees, one being the Executive Council of the Berkeley chapter of Phi Beta Kappa, of which she was a longtime member and held various offices over the years, the other being the Learning and Retirement Committee itself, which she chaired before I did. She was devoted to the projects and purposes of these committees, and even in her final year when she was hampered by illness, she tried valiantly to participate. In these contexts, her dedication to helping others and upholding the highest standards of engagement in research, teaching, and public service of the university are always clear to see. In her research, Carol was strongly committed to the concept of equal access to health care and to improving the health of populations generally neglected by the heavily for-profit American healthcare system. On behalf of Director Carrie Sweeney, the LAR committee, and all of us, I want to express our gratitude for Carol's contributions of time and effort during her life and for her generosity in endowing the retirement center programs. I'm very glad to note that her daughter, Lisa Bloom, is with us today for this lecture. Turning to today's event, today's speaker is Ann C. Keller, who is Associate Professor of Health Politics and Policy. Her research projects focus on exploring the nature and use of scientific and technical expertise in public decision-making. She received her BA from Indiana University with a double major in mathematics and political science. She came to Berkeley to pursue her graduate study, receiving her PhD in 2001. Keller's training also included a 2-year postdoctoral fellowship with the Robert Wood Johnson Foundation's Scholars in Health Policy Research Program. Professor Keller studies the politics of science and expertise in public policy, focusing on environmental, health, and technological innovation. Recent publications focus on how politics shapes aspects of the implementation of the Affordable Care Act. She is currently a principal investigator of a grant funded by the National Science Foundation's Science of Science and Innovation Policy, studying public sector responses to CRISPR, Cas9, and to automated vehicle innovations. The titles of some of her recent articles that she authored or co-authored will give you a sense of the questions that she addresses. In 2020, Turning Off the Tap, Trump, the GOP, and Regulatory Science. Again in 2020, State Politics and the Uneven Fate of Medicaid Expansion. In 2021, The Loss of Capacity in Public Organizations, a Public Administration Challenge. And in 2023, Comparing Regulatory Processes in Genome Editing and Autonomous Vehicles, How Institutional Environments Shape Socio-Technical Imaginaries. Today's topic is equally germane to our current societal and political conditions. I'm very pleased to welcome her here today to speak on Embracing Controversy, a second look at CDC reforms after COVID-19. Professor Keller.
Thank you so much. Thank you so much for that introduction, Donald. I'm delighted to be here and delighted to be able to come and join you and talk about this topic. I began studying pandemics and pandemic response. I'll just give a little bit of background about this aspect of my research with an initial grant. I guess actually when I was doing my Robert Wood Johnson fellowship, I started focusing on the CDC and thinking that the CDC was sort of an interesting organization, and in that it was trying to be a scientific organization in the public domain. And I began studying pandemic response around CDC's around the global response to H1N1 in 2009, and then had the opportunity to look at the WHO and the CDC's response to 2014 Ebola. So when I began to during COVID-19, I already had a little bit of a sense of some of the complexity of trying to write guidance, from trying to guide a response during a pandemic when you're learning as you're going. And I think that's informed a lot of what I'm doing here. So I'm gonna, without further ado, I'm gonna see if I can share my screen and make sure everyone can see my my slides. and let's get started. Donald already said that, already read out my title, Embracing Controversy, a Second Look at CDC Reforms After COVID. And I recognize that I think, here we are only a few years after COVID has ended, and I'm taking us all right back into it. So I hope you're ready for the deep dive. I wanted to just give a little bit of a motivation and try to say how I'm breaking up the sections of what I want to present today. And one of the things that concerns me when I look at both criticism and reform efforts that the CDC has signaled that it's undertaking is that it seems that both the critics and the reformers are using what I would call sort of a model of scientific closure, as if that's available to people who are trying to guide pandemic response efforts. And I'm not so sure that that's the case. And so I want to ask, would we design reforms differently if we took seriously that oftentimes we're trying to shape pandemic response, we're trying to create policies with a lack of scientific closure? I also think that there's an emphasis within the CDC to try to be simple about guidance, to try to make sure that guidance is easy to understand and sort of simply packaged. And I certainly think that there is a lot of value in that. You don't want to confuse people. And yet I also think that there's an amazing amount of complexity that goes into any decision about how best to respond to a pandemic. And so I want to see if I can think about reforms that could create an opportunity for simplicity and complexity to sort of both have homes, for want of a better term. All right, so how am I going to take us through this conversation? I want to get across the concerns of critics and reformers, and show some of the dynamics I think are happening around criticism of what went well or what went poorly. And then I want to take us through the way that the scholarship coming from the field of science, technology, and society tries to inform us about how novel scientific claims gain standing. And I think that a lot of the social science research about how science functions in society could help inform reforms better than I think the way that we sort of traditionally think about science. And so that's going to get to this question of scientific closure. And I want to walk us through a case study. I want to look at CDC's 5-day isolation guidance, which came out in December of 2021. And I want to show both how the media treated that guidance, the impression that the media gave of the science that was being contested. And then I want to start thinking about the implications of that by talking about what I think could be sort of an enhanced reform strategy. So let me see if I can walk us through each of those chapters. And I'll begin then by asking what seems to be motivating both critics and reformers. And what do I think are their implicit assumptions about patterns of learning during a pandemic, and especially one driven by novel infectious disease. So just to begin here, on the left-hand side of this slide is New York Times, is just a screen capture from the New York Times, where Biden's CDC director, Rochelle Walensky, says that the CDC oversaw a botched pandemic response and that she's calling for reforms. And in doing the research, actually, sort of around this topic, what I wanted to look at is well, what are people saying about how CDC failed? Because I think the idea of sort of CDC failure is really quite out there in the public mind. And what I found was something kind of surprising, and only part of it is actually sort of showing up here. But when I look at scholarly publications around the U.S. failure during COVID, which was the failure having to do with the fact that a wealthy country that was well prepared had such high rates of transmission and such high rates of death from COVID. What I found is that most of the scholarly literature, most of the social science literature actually doesn't point to the CDC at all. You don't see that table on this slide. I didn't want to busy you with too much of that. But when we look at where criticism is coming from, I think there's sort of an interesting story that I wanted to pull out here. And so the table comes from the manuscript that goes with this talk. And on the left-hand column of that table is what CDC's critics are saying. That the CDC had limited data collection capacity, its case definition for COVID was flawed. There were publications that said that CDC's guidance was incorrect, that it had to reverse itself. It issued guidance that was unenforceable. It issued guidance that will increase transmission instead of preventing transmission, that it had communication failures around guidance. And of course, I think many people who are critical of the CDC note the testing failure. And what I wanted to do here with this color coding is that I wanted to show that really there's an interesting pattern around the way that people who's saying that CDC failed. And 17 of the stories that are listed here and the references actually come from the media. There are 4 published papers that have their similar criticisms of the CDC. And when you read those papers, they cite the media story saying that the CDC failed. There's one unpublished manuscript here by Greer and Oberlander, and they tend to do the same thing. When they want to say CDC failed, the way they do it is they show stories where news media were criticizing CDC's guidance. Okay, so I'm not sure that I want to make too much of a point about that, but I want people to know that that dynamic is there. And the next, so this slide, I want to attend to the testing failure. I think that CDC issued tests which were flawed and were producing, I think, false. And I'm going to get this wrong. Were they producing false positives or false negatives? In any case, I think we can all remember that early in the pandemic, the test that was developed by the CDC had to be recalled because it was not working properly. I think that when I look at that case, I think that it was a pretty simple management failure and a coordination and quality control failure. There's a report that's been conducted about how that failure occurred. And there's also been work done at the CDC to improve its ability to develop tests and to distribute them. And in purple on the right-hand side, in the CDC's own description of its improvements around testing, they argue that they were able to use this new system and increase testing around mpox from 6,000 tests per week to 60,000 tests per week. So they're arguing that they've actually corrected this problem. So I want to acknowledge that I think the testing problem was real, and I think that it's that its current reforms actually have likely managed the management and coordination and quality control issue. So I'll move on from testing, and I want to focus on the way that the CDC, if I go back to this table, if I go back to this table, most of what the focus here is on sort of the problems with guidance, guidance reversals, guidance not being well thought out, communication around guidance being sort of muddled. And I wanted to just sort of give two examples here. This one is from the Washington Post. We have the headline, CDC's mask guidance spurs confusion and criticism as well as celebration. A bit of a balanced headline. We don't always see that. And then over here on the right-hand side, you see that what the Washington Post is telling a story where around the masking guidance issued in May of 2021, where the CDC was saying, if you're vaccinated, you don't have to wear a mask indoors. So they cite, and what I did here was I sort of highlighted in red all of the sort of negative connotations that the Washington Post brings to the guidance. And then in blue are the things that maybe are the positive connotations, where the blue is that some people hailed the relaxation of restrictions. It's a milestone, a return to normal, their celebration. But the Washington Post, I think, is more telling us a story about confusion, scrambling, experts questioning the sudden guidance. They go on to say that more than a dozen physicians that were interviewed expressed concern that the decision was premature. And that the guidance was, in this particular case, I think the criticism is that if people were allowed to not wear a mask indoors, people who weren't vaccinated would follow that behavior, and that would lead to sort of increasing transmission. And what I guess an interesting thing to point out here is not just the dynamic around the fact that this newspaper article included 6 experts who were critical and 2 that were supportive. I think we tend to see that kind of dynamic in the media. While they may cite some supportive experts, they tend to cite more critical experts. And yet we really don't know whether that 2 versus 6 is representative of the larger expert community. It's never really explained. It's sort of left unexplained. I think in this particular case that the Washington Post is sending a message to maybe not put a lot of confidence in this guidance. And if for those who remember this particular period, by the end of July, the CDC had actually reversed the guidance. They had pulled it back and said, look, because of Delta, there are enough breakthrough infections among people who are vaccinated, that we want people who are vaccinated to start masking indoors again. So in this particular case, you might think, oh, well, this, the media is doing this great job. They're calling CDC issued guidance. There are experts who are questioning it, and it turned out, in fact, the CDC had to reverse its guidance later, and that may not be a negative story at all. In this next example, this is an example that has some similar dynamics. Here, I think the headline sort of reflects more the critical experts who are cited, rather than the fact that there's some supportive uh, um, uh, perspective being shared as well. But this is guidance. Again, I've moved to a different element of CDC's guidance. This is guidance related to CDC's isolation period, where in December of 2021, the CDC said, if you had resolving symptoms and no fever, you could return to work or return to normal life after 5 days of isolation. And I think that here, what I want to just pose this as a question, because we're going to get into this case a little bit more deeply. I want to ask if that same thing happens where the critics are sort of proven correct. So that's one storyline, is to think about when there are critics of CDC guidance, does that mean that the guidance itself is flawed? And what I want to say is that I'm not sure we necessarily always know. At the same time, I think the CDC, for its part, seems to concur that there were real problems with the way that it issued guidance. And the CDC has now on its website a report that looks at what the CDC thinks its failures are, and that articulates some goals as well as strategies for trying to achieve those goals. So the report is called CDC Moving Forward. It was issued, I think, in August of 2022. And the report says, we acknowledge the CDC is responsible for some large public mistakes. And among they've been their goals into sort of 5 categories. They want to share scientific data faster. They want to translate science into practical, easy to understand policy. And then they want to prioritize health communications. They're interested in developing a workforce that's better prepared for emergencies. And this last one, they want to promote results-based partnerships. I'm going to focus less on the goals 3 through 4. But I wanted to just call out a couple of things that they say in their report about the first 2. So related to the first goal of sharing scientific data faster, they write that a variety of stakeholders rely on CDC for their expertise. The information that the CDC might share is time sensitive and urgent. But at the same time, the latest scientific information might not always be definitive, complete, or fully analyzed. However, if the CDC isn't sharing the latest information in a timely and understandable way, people will have to make decisions without the benefit of the agency's expertise and knowledge. One of the things I think is interesting here is that the CDC is sort of they're acknowledging a tension that you don't always know what's best. You don't always have all the information that you need, but they're still sort of pushing on this sort of speed and urgency aspect of what they need to do. When it comes to translating science into practical and easy to understand policy, they write that their guidance documents were often long, overly complex, with a large number of caveats and footnotes. They're saying that the central message of the implementation guidance became obscured. It was misinterpreted by the public and the public, the media, or other stakeholders. And in certain circumstances, the science or the scientific background was only published after the release of guidance. So here it seems like they want to say that if they can share their science faster, they're going to be on more sure footing. And so I want to just look a little bit more deeply, because this is sort of more a set of goals than it is really reform efforts. So I want to just I want to look under the hood a little bit about what their reform efforts are. They have a new strategy for developing and distributing tests, and they say it's working. They've also developed what they think is, they've developed an electronic case reporting strategy, where instead of having to manually sort of call and interact with hospitals around a spreading infectious disease, there's a way that case reporting can happen, that CDC can get data essentially automatically from electronic medical records. So I think they're sort of imagining that they're going to have better access to data And it's going to be easier to sort of tell where there are cases and what the status of someone who is hospitalized or with COVID, for example. They're also trying to develop better modeling. So they want to rely on being able to not just collect data about spreading a spreading infectious disease. They also want to be able to predict what's likely to happen. What are the dynamics that they should expect with that? And they've reinstated a body of external advisors to the director that I think was dissolved early in the course of the pandemic. And I think all of these sort of fit in with CDC's reform efforts to try to speed up its data collection and analysis. It wants to know what's happening, and it wants to be able to analyze data in order to sort of achieve that goal of translating science into easy to see. And I think that they also recognize that they need to communicate better. Although here I think that their reforms look a little less elaborated. They want to improve their website, and they're gathering stakeholder feedback about how to do that. They're saying that they want to share real-time data, which I think sort of falls loosely under the communication strategy, but they haven't really said how they would do that. What does it mean to share real-time data? And what I would love to know more is that validated data, or is that unvalidated data? And if it's the latter, could there be a problem with sharing real-time data? And then they sort of reiterate that they want to translate science into easy to understand policy. And there are a few other concrete reforms. They want to have more trained personnel, this better workforce. They want to focus on health equity. And they're also trying to build some local public health capacity through grant making. On the right-hand side of this slide, I include that the CDC, and this image here isn't associated with reforms per se. I think this image of 6 principles of crisis and emergency risk communication is something that predates COVID. But I think when I read through some of these principles, you'll see that I think you'll see that the CDC seems to be, I don't think has rewritten any of its principles. I think it's still sort of using this idea of needing to be first. It wants to be the first organization that says something about an emerging pandemic. It wants to be right. And then I think within that, I guess, or connected to that, is to be credible, to be honest about information. And then there are some guidelines about how to interact with people. You need to express empathy. When you write guidance, it needs to allow people to act to sort of better protect themselves. And then the organization should be very respectful in the way that it communicates. And I want to really focus here, I think, on the way that it's that being first and being right seem to be very important to the organization. And I think that if you dive into the way that the crisis and emergency risk communication literature is written by CDC, that they seem to assume that being first and being right is going to lead to credibility. All right, so I want to ask about whether or not, does it make sense to be trying to do things faster? Or I guess I want to explore whether or not I think some of these reforms are going to change the way that CDC's guidance is received. So they seem to be emphasizing be first, be right. They really want to translate science into easy to understand policy. And I want to ask, how do you demonstrate that you're right? How do we know if the CDC is right? I'm also really interested in what do you do when the facts on the ground change? And I think that potentially the case around CDC saying that people who were vaccinated didn't need to wear a mask indoors, that may have been true by the evidence that they had at the time. But once the new variant Delta arrived and produced more breakthrough infections, the CDC found itself in a situation where it needed to change. And I think that's an interesting problem if the CDC simply wants to be right. They weren't necessarily wrong in May of 2021 in that they didn't know that the Delta variant, that a new variant was going to come along that had a different level of breakthrough, or a different percentage of breakthrough infections for the vaccinated. So it's an interesting construction of what it means to be right. Do you have to know the future, and does being right mean being omniscient? So I want to delve into this, and I think I'm going to continue to. While I do recognize that guidance needs to be simple and easy to understand, I think that the public can also learn from uncertainty and complexity. So I want to delve into that a little bit. All right, and here is, I'm going to take a pause here from looking at CDC's, the critics and the reform, what the critics were concerned about and how CDC has sort of internalized that criticism in the set of reforms. And I want to introduce what I'm calling, I just sort of colloquially, a treasure hunt versus a social discovery model of science. And what I'm going to do here, because I'm packing up quite a bit of social science into a short space of time, I'm actually just going to read from my paper to keep myself from going, getting into this sort of too deeply. So I want to talk a little bit about the way, the contribution that I think science, technology, and society scholarship has made in terms of informing the way that we understand how science works in society. And for me, as someone who looks at science in policymaking, where science is quite heavily contested, I find that the STS approach does a better job of empirically predicting what we actually sort of experience. So let me just read through how I frame this in the paper. So one of the central contributions from the STS scholarship is the finding that social processes determine what is considered factual in scientific communities and beyond. STS scholars themselves have long disputed the idea that facts are discovered merely through objective means. And here's where I want to introduce the idea that there's of this sort of treasure hunt model that I'm going to use as an idiom. So according to traditional models of scientific discovery, facts are understood as such because of their inherent factness. If you're using this view, once a fact is articulated, a fact will emanate sort of unmistakable characteristics that sets it apart from any claims that are not factual. An expert presented with a novel fact by someone in their field may take nominal time to independently verify that fact. But that verification, because facts themselves are so clear, will be straightforward and uncontroversial. I think there's a corollary about how non-experts should come to appreciate facts. I'm not going to go into that here. But let me just argue that that the STS scholars are sort of disputing this traditional view. So the STS scholars, critics of STS scholars, I think, have argued that the STS approach assumes that facts are made up. And the STS scholars would say that that's not true at all. In fact, they believe that facts are real and scientific things can have, scientific claims can be factual. But they're looking at the social processes by which scientific communities are able to separate conjecture from what comes to be viewed as robust science. And I think there's a lot of ethnographic work that went into this. And I put up Latour and Woolgar's laboratory life as an example of that work. And Latour, in particular, in 1989, makes this argument that that the way that claims, when we're thinking through ethnographic work, cataloging the emergence of new scientific discoveries, Latour and Woolgar were able to show that novel claims were treated by the larger scientific community as contingent. And neither claims nor counterclaims among people who were following what was happening had any standing as factual until after a long period of protracted debate. And so Latour sort of summarizes this by saying a matter of fact is a late outcome of a long process of negotiation and institutionalization. To be indisputable is the end point, not the beginning. And I think that's, for me, it informs the way that we would think about reforms during COVID. If you're learning something new about the world, that new thing that you learn is very unlikely to have standing as fact. And so I think that there's a real difference when we think about the sort of traditional model. If you've discovered a fact, everybody knows that you've discovered it. They can point to it. You've discovered something like as in a treasure hunt, and you can say, look, I found the treasure. And everyone can see you found the treasure, and you can move on from there. All right. So what do I, when in thinking about how what do these two models, what would they say about how you would respond or how you would generate policy if you are learning new things about the world when a pandemic driven by a novel infectious disease is occurring? So I have a table just to try to sort of summarize what I think some of the implications are. So the method for identifying facts in the treasure hunt model is that sort of the inherent characteristics of the fact themselves are sort of their objective means by which you can test whether something's factual. What I'm calling the STS model, the social discovery model, actually says what gets determined as factual has more to do with the density and extent of social networks of acceptance. So we actually understand facts based on who begins to use claims as if they're factual. And unlike in the treasure hunt model, where there may be a clear demarcation surrounding the discovery of something new, in the social discovery model, there is no clear demarcation. Um, uh, so that leads to sort of two different realities, I think, or two different understandings of what experts might do when they're presented with novel scientific claims. In the treasure hunt world, once an expert sees something factual, a new fact is claimed, they recognize it as a fact and they accept it. The STS literature and empirical evidence says actually we should expect debate and sometimes protracted debate. Responsive non-experts. In the treasure hunt model, people presume that the response of experts has to do with how scientifically literate you are, how scientifically literate the public is. The STS model, the social discovery model, says that acceptance of facts is really shaped by factors other than the quality or understanding of science. It can be shaped by ideology, familiarity, and trust of who's making a scientific claim. And there's a couple of other things that this table suggests. One is that uncertainty should decrease with time under the treasure hunt model, whereas social discovery might mean that uncertainty is actually expanding. And I think the treasure hunt model sort of assumes that one-time communications are sort of sufficient for convincing people that something true about the world has been discovered. Whereas the social discovery model assumes that communications are going to require interaction, sort of ongoing communications between claiming communities and receiving communities. And I think the social discovery model also assumes that that scientists can be learning from non-scientists in these processes of social discovery, or that claiming scientists and counterclaiming scientists are learning from one another as well. Whereas in the treasure hunt model, the idea is the person who's found a fact is simply just informing some other person about that fact. So these, I think, my own assumptions about the way that science can and might shape public policy really follows what's sort of on the right-hand side of this table. Which suggests, I think, that pandemic response is going to be a lot more complex than either the critics assume, and certainly than I think CDC reforms currently assume. So I tried to just picture or sort of demonstrate or create a slide that would show how I'm thinking about this. And I think this is the model of science that's embedded in CDC reforms. But there may be a period of scientific uncertainty, but with its speedier data collection and its higher analytic capacity, the CDC is going to figure out what's what. It's going to translate that into easy to understand policy. It can share its guidance with media and stakeholders as long as it's communicating with empathy and finding and correcting rumor. The CDC will be taken as credible. And so across the bottom, I think what we see is that the CDC is sort of expecting this ability to create scientific closure around these newly discovered claims or these newly discovered facts, if you will, about a novel infectious disease. And what I would say is that actually that's really unlikely. In fact, scientific uncertainty is going to extend well into the pandemic. And I think there's even evidence that things that were being debated while I think we're still debating whether or not how successful masking is in interrupting transmission. So oftentimes periods of uncertainty, I mean, this may even be an overstatement of when in the process of learning scientific uncertainty is resolved. And so what I want to do is I want to ask, does that mean that we shouldn't try? Does that mean that the CDC shouldn't try to be first and be right? But what I want to suggest is that there's a way for the CDC to continue with the reforms that it is pursuing, but that we might actually want to build an additional element to reforms. And this is how to think about this is maybe just an illustration of what it might look like to take the social discovery model seriously. I don't want to assert that this is the only way to think about building reforms around a social discovery model. But I want to ask whether or not a venue that could host conversations about both science and policy during a pandemic, and I would nominate the National Academies of Science and Engineering and Medicine as to be the right place for that. And we can talk a little bit more about that, why I think they might be good at it. And that an institution, and for the purposes of this talk, we'll assume that's the National Academies of Science, Engineering, and Medicine, could try to have a set of conversations that emphasize sort of learning over knowing, and that they might treat controversy and deliberation as necessary and functional. We should expect experts to be disagreeing and debating whether or not the science is right, and even disagreeing and debating whether or not guidance or pandemic response policy will work. We can learn from experts who are having those debates. And I think potentially a little bit of that is happening in the media, but I think the media actually is more interested in kind of covering controversy than it is in really sort of looking at how these debates unfold over time. And I want to use the 5-day guidance example to walk us through that. I also think that creating a venue that's really, that part of its mission is to get into the complexity, to really acknowledge complexity, could provide something that I don't think the media is well structured to do. And I think that to the extent that people are, working in this treasure hunt model where clear scientific facts are going to tell us obviously how we should respond to COVID, really overlooks the fact that at the end of the day, pandemic response is incredibly value laden, and we're going, even if we understand science very clearly about how transmission is happening, that doesn't mean we're necessarily as a society going to agree about the best way to intervene. And so trying to create a venue that can address some of that, I think could be better. All right, so why do I think that? So this is chapter 3 is here. I want to get into the details of the CDC's 5-day isolation guidance. And I'm going to rely on John Swartzberg, who is much more of an expert in this. I'm a political scientist. I don't have infectious disease training. So if I make mistakes as I go through this, I'm going to rely on John during the Q&A to help thread the needle for us. But let me just begin by reminding people what happened. So this is this is a screenshot of CDC's press release that it put out on December 27, 2021. So this is about a year into vaccination. The CDC updated its isolation policy and said that if you test positive for COVID, you need to stay home for 5 days. But if you have no symptoms or your symptoms are resolving, you can leave your house. And here in this particular screenshot, they mention if you have a fever, please continue to stay home until your fever resolves. So part of their guidance around symptoms is that you need to be fever-free. And I think in one version of this, they even clarified you need to be fever-free for 24 hours. If you do this, if you have these resolving symptoms and no fever, you should wear a mask for 5 additional days. All right. This guidance prompted quite a bit of criticism. And here on this slide, I just have grabbed a bunch of headlines where news outlets over the next few days were raising questions about the guidance itself. And I want to get into the argument. I think so. There were many critics. I think one of the things that was happening with the media coverage is that the media was doing sort of that same thing, where a number of critics were being held up, I think, as speaking for the larger expert community, when I'm not sure we know that that's true. And this is sort of the nature of how the media presented this. The critics' argument was that without a negative test to show that you're no longer infectious, almost half the people leaving isolation will be able to transmit the virus. And so I want to talk a little bit. The next slide is going to get into why people were assuming that really high numbers of people who might follow CDC's guidance might still be able to transmit the virus. So one of the arguments that critics made was that the CDC had based its policy not by studying the Delta variant, not Omicron, and that Omicron could be much worse in terms of transmissibility later in the course of infection. So that the critics were basically just saying CDC guidance is going to lead to a spike in transmission. The CDC is just allowing people to leave isolation before they know for sure that they're testing negative. And the CDC was in supporting its guidance was saying most people are likely to transmit COVID 1 to 2 days before the onset of symptoms, and then up to 3 to 5 days after symptoms have begun. The CDC also wanted to communicate, and they did, I think, even in some of the media stories, that a positive test is not a good proxy for the ability to transmit COVID. So you can test positive even though you're no longer shedding viable virus. And what they were arguing is that if you followed that guidance, if you have resolving symptoms, if you've stayed at home for 5 days, if you don't have a fever and you're wearing a mask, you're very unlikely to be able to transmit the virus. That's sort of and I do think that the media got here. It got these two stories out relatively effectively. But one of the things I think that the media didn't do was it didn't really sort of delve into the nature of what people were arguing, or the nature of the scientific argument. And I have just an example here where the New York Times was looking at studies that were saying more than half of the people who were testing positive. And there's a couple of things that I think are that the CDC was trying to respond to with that. They were saying that, first of all, if testing isn't a good proxy for transmissibility, we don't necessarily know that the people who are testing positive can transmit the disease. And I think many of the studies that at least in this particular New York Times piece, they weren't looking at whether or not they didn't separate the people that were being tested into those who met CDC's criteria for leaving 5 days early. So I think that would give us sort of an overestimate of how many people were testing positive. And I think so. A couple of studies were tried to get at the issue of whether or not test positivity is a good proxy, because they were looking at what they called PCR cycle threshold values that they were suggesting were a proxy for potential infectiousness. But since they weren't testing only people who met CDC criteria for leaving isolation, they may be really overestimating the numbers of people who would leave isolation if they were following CDC guidance. One of the things that I thought was particularly interesting about the New York Times, the way that the New York Times handled this, is that they didn't note that one of the studies that they had cited had a really strong conflict of interest, and that 7 co-authors of the study had a financial interest in Tempus Labs, which is a company that was selling at-home COVID tests. All right, so I think what I would suggest is that if something like the National Academies of Science, Engineering, and Medicine were handling this, they might be able to get at this question of whether or not these studies whether or not you could draw the conclusion that the New York Times drew from these studies. Could you use these studies to show that in fact people would be leaving isolation and be able to transmit the virus? And I think that these studies, what I'm going to argue is these studies could not lead you to that conclusion. We don't know for sure whether that or not that's the case, because they weren't really testing people who met CDC isolation guidance. I did find a study, and sort of looking at how all of this was resolved, I found a study that came out months later, August 3rd, 2022, where, and I don't think I'll spend too much time on this. It's a pretty small study where they did actually test people who met CDC's criteria, and they found that less than 25% of them were able to produce a positive viral culture. And I'm going to leave it to our infectious disease experts whether or not being able to produce a positive viral culture in a lab means that you can transmit the disease. But CDC's argument at the time was, if you're in this category, this less than 25%, and you're wearing a mask out around other people, their contention was that it probably wasn't. You probably weren't likely to be able to transmit. All right. So one of the things that I think is problematic is that I think that the media at the time really gave a misinterpretation of the implications of the reference scientific studies. They used the idea of getting a positive test as proof that you could transmit when you couldn't draw that conclusion from those studies. They also tended to see a lack of scientific closure as evidence of faulty guidance. So they're looking at, I think the media is basically just saying, because there's experts out there who are critical, that means the guidance must be wrong. And I don't think the media took any time to sort of follow the controversy to see how it was resolved. And I want to take us through that, through one example, I guess, of that. And that is that the CDC 5-day guidance gets picked up by multiple states and by multiple countries after the CDC guidance is issued. So what I want to suggest is that other public health authorities who were making independent decisions about guidance brought their guidance in line with what the CDC was doing. So what do we have here? We've got Australia doing it. We have Denmark doing it. We have, I think this is the NIH case is actually from Scotland. Vancouver in Canada is doing it. Japan follows the guidance. California, the state of California, initially didn't follow the CDC guidance, but then by January of 2022, does begin to follow the guidance. All right, so this, potentially you could see this outcome happening if I guess you could see this outcome happening not simply because experts, independent experts became convinced, but I think that's the most likely story here. And I want to suggest this figure here is a way to try to capture the idea that that the media, when they're oftentimes quoting a handful of critical experts, or give the impression that the CDC is sort of is operating without the support of the expert community. And what I would argue is that it's possible that that's actually not true, that the CDC has quite a bit of expert support. And potentially in the case that we're looking at, the CDC didn't have it at the outset, but it generated it over time. And the social discovery model would argue that that's we actually should expect we should expect novel scientific claims to be contested before they are accepted, and that's actually a part of normal science. There's nothing wrong with that dynamic happening. And so one of the things that I, when I think about what's happening when I look at CDC reforms, one of the things I want to ask is, well, is it easy to prove you're right? What if it looks to me that when I think about the 5-day guidance, the 5-day isolation example, it looks like the CDC met its own internal criteria for doing well, in that it was first, it sort of really led with this 5-day isolation guidance. And that after a period of debate about whether or not the CDC guidance had merit, it looks like public health experts kind of across the globe begin to see it as a valid way to respond to the pandemic. So this raises for me the question of whether or not you can prove I think this goes back to sort of, is the treasure hunt model helpful? Because if the CDC is first and right, and yet it's still treated in the media as if it's wrong, the media may be sending a signal, I think, to the public that guidance that's valid isn't valid. So I wonder if we need to build sort of additional ways to delve into some of this complexity. And I would also say, in looking at the way that the 5-day guidance played out, there were many additional considerations that came into releasing that guidance when the CDC released it. And this gets into the question of whether or not, do we know exactly what to do once we understand the science? So there's a few other considerations here. There was really low rates of compliance with the 10-day isolation guidance that was being replaced. The CDC was anticipating a healthcare worker shortage. And so the idea of having people stay home when they weren't going to transmit the disease could exacerbate that shortage. And they issued the guidance in a period where there was a shortage of tests available. So if having a testing strategy to get out of isolation was part of the guidance, and there's a shortage of tests, then you would once again be keeping people who maybe couldn't transmit the disease home for longer than necessary. So this is where I want to sort of think about whether or not we would still want the CDC to be issuing sort of simple, straightforward guidance, but we might want to have another venue that can delve into complexity, because I think that there's incredible complexity with what was happening around the 5-day guidance. And yet, still think the CDC sort of met their criteria for being first and arguably being right. All right, so let me just try to wrap up here pretty quickly. That I suggested this sort of earlier. I wanted people to kind of know where I was going with all of this. And I wanted to say a few things about how I think, how would deliberations sort of work? And I think one of the things that the CDC should continue to, in my version of reforms, the CDC sort of would retain its normal roles and responsibilities. even if that meant emphasizing sort of speed, validity, and clarity. If there were an additional venue that was hosting deliberations, what would be very important is that venue is not a policy generating venue, and that what they would be doing, what I would hope they would do, is that they would convene major stakeholders for deliberations, but they would do so sort of emphasizing uncertainty, learning, and complexity as a normal part of responding to a pandemic. And I list over here on the right hand side the kinds of organizations that I think would arguably be included. And I think one thing that would be really important about having organizations be represented, and not just not just maybe hand-selected experts, is that you would more quickly, through a venue that's including organizations, you might more quickly understand the kind of extent of support for CDC guidance among experts, or a lack of support for CDC guidance. And you might be able to get a sense of whether or not support is waxing or waning over time. Um, so I think that that's important for a number of reasons. One is that the CDC isn't always going to be right. I mean, sometimes there will be scientific information either they're not able to collect, or the science will change underfoot as they're responding. And having another venue that can sort of delve into that and try to explain why that's happening is, I think, is a source of learning and maybe a source of information for the public. I'm going to just breeze by this slide. I think there's some supporting scholarship that suggests there are reasons why that could work. And I want to just close by saying that I think there's a number of advantages of thinking about a system where the CDC still continues to try to meet its own criteria for how to respond well in a pandemic. But we include this a more reliable, or not, sorry, I'm choosing my words poorly there. We include another venue that has a slightly different mission. So I think there's some redundancy in a system that would include the CDC doing what it's doing and the National Academies of Science and Engineering and Medicine hosting deliberations. I think you'd have two organizations that are trying to inform the public during a pandemic, and that their different emphases and distinct reputations could actually leave the public better informed. I think that just the idea that deliberations should be happening could help normalize the notion that science isn't going to science won't emerge as in a treasure hunt, that it'll be much more, things will be much more sort of fluid and uncertain. And I think I've already mentioned that I think that deliberative organization that's included, a deliberative venue that's including organizations, could give a better sense of what the actual distribution of expert support or criticism is. I also think it could be very important, and I imagine we'll focus a little bit on this in the Q&A, it could be really important to have an organization that sits outside of the executive branch that's available to provide information to the public about a pandemic. And then once again, hosting deliberations, I think, could really sort of normalize the idea that learning is both difficult and and sometimes error prone during a pandemic, and even under normal scientific conditions, how scientists sort of debate things before novel claims gain standing is a normal part of the science process. I think there are multiple disadvantages, and probably the disadvantages column could be longer, but I'll just point out a few here. Would anyone even pay attention? Who's listening, I guess, is a sort of open question. And in the manuscript that I have under review right now, my reviewers are really, really focused on this. Would anyone care? There's a potential that opening the black box of science, like I'm suggesting, could make the public less confident in guidance. And I think there's some of the peer reviewers who have looked at the paper are really worried about the fact that this organization would become politicized.